Hello. So we're going to continue on with the forearm and elbow, and we'll go over the humerus next week. So the general procedural guidelines. For patient preparation, general patient position, the IR size, your SID, your markers, radiation protection, and giving instructions to your patient. So general patient preparation for all procedures of the upper limb require removal of radiopaque artifacts from the anatomy of interest, including watches, rings, any bracelets, and make sure that you do secure all patient possessions in designated manner and location, or make sure that the patient keeps his items or her items with them when they go into the room. So ambulatory patients, radiographs of the forearm and elbow are taken with the patient seated at the end of the x-ray table. The patient's effective limb rests on the IR placed on the tabletop. Non-ambulatory patients' position can be altered to allow imaging of this anatomy with the patient in the bed or a stretcher in a supine position. Humerus radius may be obtained with the patient standing or seated, upright or in supine position, or the radiographic table, or on a stretcher. So the IR collimated field, you can go corner to corner at an angle if the patient has excessively long limbs, to make sure that you get both joint spaces in your wrist joint and your elbow joint. Generally, you can go perpendicular, but in some cases you may have to go corner to corner. So make sure that you do put the lead apron on the patient or a lead strip over the reproductive organs, and make sure close collimation and use of optimum technique factors also protect the patient from unnecessary exposure. The essential projections of the forearm, pretty basic. It's an AP and a lateral. So collimated field size, 2-inch distal to the wrist joint and proximal to the elbow joint, and 1 inch to the sides. So that's what you want to see, making sure that you are 2 inches above the wrist and 2 inches above the elbow joint, 1 inch on the sides. So the elbow is extended with the hand supinated, the upper limb in the same plane, the humeral epicondyles equidistant from the IR, long axis of the forearm aligned parallel, and the septal rays perpendicular to the IR and enters at the midpoint of the forearm. Here's a criteria for the AP forearm. Entire forearm include the wrist and the distal humerus. Slight supination, superposition of the radial head, neck, and tuberosity over the proximal ulna. So we see here. No elongation or shortening of the humeral epicondyles. Then partially open elbow joint. If the shoulder was placed in the same plane as the forearm, you see the open radiolunar space. Similar imaging, brightness and contrast of the proximal and distant forearm. So making sure that its contrast is similar on both ends. Soft tissue and bony trabecular detail, which you can see some soft tissue here. Lateral forearm, with the entire upper limb in the same plane with the forearm resting on the ulnar surface. So you want your shoulder to be at the same level. The elbow flexed 90 degrees, the ulnar and radial styloid processes superimposed, and the long axis aligned parallel with the IR. CR perpendicular to the IR, and it enters the patient at the midpoint of the forearm. So here's the image. The humerus in a true lateral position. Superposition of the radius and ulna at the distal ends. Superimposition of the radial head over the coronoid processes. The radial tuberosity facing anteriorly. Superimpose humeral epicondyles. This area here. And the elbow is flexed 90 degrees. And you can see soft tissue detail along the entire length. So essential projections of the elbow. You have the AP, the lateral, AP oblique. Included in the AP oblique is the medial rotation position, the lateral rotation position, which is generally the most common. You have your AP partial flexion position to demonstrate the distal humerus, and the partial flexion position to demonstrate proximal forearm. And then you have your axiolateral, which is your coil method that we'll be covering. So essential projections of the elbow: collimated field size, 3 inches proximal and distal to the elbow joint, and 1 inch on the sides. So you can see here your central raise at the elbow joint. You want 3 inches on either side and 1 inch on both sides. So we want to make sure the upper limb is the same plane with the posterior surface in contact with the IR. See which is shoulder at the same level here. The elbow extended in the hand is supinated, so palm up. Elbow centered to the middle of the unmasked portion of the IR. Humeral epicondyles parallel with the IR, and the CR is perpendicular to the elbow joint. I want to see this position here. If the patient has an injury to their elbow, this is very difficult to get them to extend it fully. And in those cases, we'll cover how to get the image if the patient is able to hold this position. So here's evaluation criteria for the AP elbow. The radial head, neck, and tuberosity slightly imposed over the proximal ulna. So you can see here that it's superimposed. So for that, to clear that, see the spacing here, we'll be doing the oblique, and we'll do that I'll show you in just a minute. The elbow joint is open and centered, and no rotation of the humeral epicondyles. And so you can see the soft tissue. So lateral elbow, make sure that the limb is in the same plane with the long axis parallel to the IR. Elbow flexed 90 degrees in the center of the IR, and the forearm is resting on the ulnar surface, so your thumb is up. And the wrist is in the true lateral position, and the CR perpendicular to the elbow joint. So here's the image of a lateral elbow. The elbow joint is open and centered to the central ray. Elbow is in the true lateral position. The superimposed humeral epicondyles. Radial tuberosity facing anteriorly. Radial head partially superimposing the coronoid process. And the olecranon process in profile. You can see all of this here. Coronoid process, your olecranon process. So the AP oblique elbow with the medial rotation position, the limb is in the same plane with the elbow extended, elbow centered to the unmasked part of the IR. Pronate hand and medially or internally rotate elbow to place anterior surface 45 degrees from the plane, and the CR is perpendicular to the elbow joint. So you can see here the AB oblique elbow with the medial rotation position. So the limb is in the same plane with the elbow extended. Elbow centered to the unmasked part of the IR. Pronate hand and medial or internally rotate elbow to place the anterior surface 45 degrees from the IR plane, and the CR is perpendicular to the elbow joint. So the medial rotation position isn't as common as the lateral rotation position. And this is what the medial rotation looks like with a 45-degree angle. The coronoid process is in profile. Elongated medial humeral epicondyle. See right in there. The ulna superimposed by the radial head and neck. And the trochlea. You can visualize the trochlea. The olecranon process within the olecranon fossa. And you can see the soft tissue detail. So next we have the AP oblique elbow. This is more common here. And the limb is in the same plane with the elbow extended. The elbow centered to the unmasked portion of the IR. Supinate hand and laterally or externally rotate the elbow to place the anterior surface 45 degrees from the IR plane. So you have 45 degrees. And then ideally you want the first and second digits to touch the table when the elbow is sufficiently rotated. This too could be a difficult position for the patient to hold if they have any elbow pain. And the CR is perpendicular to the elbow joint. So here's evaluation. So you can see here that it opens up right here. So by rotating at the 45-degree angle laterally, you see the spacing here. That's why this view here is more common for your oblique. And then so the radial head, neck, and tuberosity is projected free of the ulna. You see elongated lateral humeral epicondyle. You see the capitulum and soft bony trabecular detail. So here's the two. Here's your internal rotation and your external rotation. So depending what they're looking for will determine which oblique you would use, but like I said, more commonly the lateral here is used. Now this is the view that you would use if the patient's unable to extend their arm fully. So what you do is you just rest the humerus here, perpendicular beam. And you do need to do two separate images, and I'll just show you that in just a minute. So you want the humerus touching, and you can use a sponge to help hold the patient in position here. So the humerus is the same plane with the posterior surface resting on the IR. The elevated forearm is supported. Supinate hands if possible and center to the IR of the condyles of the humerus. And the CR is perpendicular to the humerus passing through the elbow joint. And that's what that view would look like. So evidence of proper collimation, distal humerus without rotation or distortion. Proximal radius is superimposed over the ulna. Closed elbow joint. Greatly foreshortened proximal forearm here, and you can see trabecular detail in the distal humerus and soft tissue and bony trabecular detail. So this would be the second view you would do if the patient was able to fully extend their arm. So on this one, you rest the forearm on the table, hand is supinated, and it's centered to the condyle of the humerus, and the CRs, once again, it's perpendicular to the elbow joint. And so this one would be the second view that you would do. And evidence of proper collimation, proximal radius ulna without rotation or distortion. The radial head, neck, and tuberosity slightly superimposed over the ulna, right over here. Partially opened elbow joint, foreshortening of the distal humerus. Let's see here. And then you want to have soft tissue and bony trabecular detail. Axial-lateral is also called the coil position. There's two different coils. One is at a 45 degree or a 90 degree, and the one's at 80 degrees, so we'll go over them. And this is used a lot of times for trauma. This is kind of a specialized view. Normally the physician will order this view separately from your standard elbows. So part position for the head, your elbow is flexed 90 degrees, hand is pronated, CR angled 45 degrees toward the shoulder, and part position for the coronoid process, elbow flexed 80 degrees, hand pronated, and the center angle 45 degrees away from the shoulder. So this is used for trauma. Part position for the radial head. If you want to look at the radial head, that's when the elbow is flexed 90 degrees, hand pronated, and the CR is angled 45 degrees towards the shoulder. And part position for the coronoid process, once again, elbow is flexed 80 degrees, hand pronated, and the center ray is 45 degrees away from the shoulder. Those are two different views. This is the 90 degree. And that's when you want to see the radial head. And then here, that's a 90 degree bend. And then here for the coronoid process, it's an 80 degree. And the CR is 45 degrees away from the shoulder. Sorry, jumped ahead there. So evidence proper collimation for the coronoid process. It's open joint space between the radial head and the capitulum, radial head, neck, and tuberosity profile, and free from superposition, with the exception of a small portion of the coronoid process. Humeral epicondyles distorted as a result of central ray angulation, radial tuberosity facing posteriorly, and the elbow is flexed 90 degrees, and once again, soft tissue and bony detail. So that's what it would look like with the 90 degree, angled 90 degrees and 45 degrees towards your shoulder. And that's what you see, the open joint spaces. And the radial head is free from superposition with a small portion of the coronoid process. Humeral epicondyle distorted as a result of the central ray angulation. You can see over here. Radial tuberosity facing posteriorly. Elbow is flexed 90 degrees, and soft tissue and bony trabecular detail. And here's the other one to view the coronoid process. So this is with the elbow at the 80 degree bend. And here's a lateral elbow with the hand supinated. So you want to see 3 inches on either side from the joint space here. There's a hand pronated. That one isn't normally done as much as the one with the thumb up. So the hand's in the lateral position. Extreme internal rotation. That's not done very often with the thumb side down. So we'll go ahead and stop right for here for now, and then we can go into the humerus next week. Thank you.